Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. As part of our extra series on COVID-19, we've recently talked about the long-term effects of COVID-19 and how the virus affects young children. Today, we'll be discussing topics related to COVID-19 in patients who are or may want to become pregnant. In conversation with our medical experts, we'll talk about vaccination during pregnancy and the risks associated with giving birth at home during the current pandemic. My guests are my colleagues, Dr. Amos Grünebaum and Dr. Frank Chervenak. Dr. Grünebaum is an obstetrician and gynecologist specializing in high-risk pregnancies and is a professor of obstetrics and gynecology at the Zucker School of Medicine. Dr. Chervenak is the chair of obstetrics and gynecology at Lenox Hill Hospital and at the Zucker School of Medicine, and I'm delighted to welcome them both to Well Said.
Thank you, Ira.
Thank you so much.
So first, tell me how the two of you have been holding up during the extraordinarily difficult times we've all been experiencing.
Ira, it seems like an eternity since this began in 2020. And I want to put this in perspective. As 2020 started, it was a wonderful time. When I look back in January and February, Amos and I were on a plane ride back from an academic meeting in Arizona, and we were so happy. Our department was doing well. Things were gelling in the department at Lenox Hill Hospital. It was coming together beautifully. We were looking forward to beautiful international meetings. As we were coming back, it was all beautiful. I went to another international meeting. I actually made it to Mecca. And as I came back March 1st, little did I know the surprise that came back in New York City. It was a shock. It was a shock. The COVID curtain came down on us. No international travel for 2 years. And it was worse than that. We almost had to move our entire obstetric service out of the hospital at Lenox Hill. This was the biggest shock in the space of just 3 weeks. And we were prepared to do so. This would have had great import to our patients, but fortunately this was cut off. As this evolved, we dealt with the challenges that were thrown upon us one by one. We didn't have to ration or triage, and it was getting better and better. I think everyone knows we're in the middle of another pandemic. And to borrow a phrase from Al Pacino, just when we thought it was over, we get pulled back in. And we're dealing with this now. And I can speak for my whole department, Ira, enough is enough.
Yeah, well, amen to enough is enough, for sure. I do want to talk specifically about COVID-19 in its relationship to pregnant women. So what do we know now, 2 years in, about the effect of COVID-19 on pregnancy and outcomes of women who are pregnant and may get COVID-19? Maybe, Amos, you can start with that.
Sure. What we know now is that pregnant women are as badly likely to become infected with COVID-19 as those who are not pregnant. In addition to this, when a pregnant woman becomes infected, there are two patients. It's her and the fetus. So we have to deal with a double whammy. And we also have done research for the last 2 years, where we found out that if a pregnant woman becomes infected, she's likely to become more sick and more likely to die than the average woman of a similar age. So it's really important that pregnant women realize they need to become aware of their increased risks.
Why is that? What is it about pregnancy that makes somebody more likely to have a bad outcome if they get infected?
There's a lot of changes in pregnancy, normal pregnancy, that worsened by COVID-19. Women have an increased blood volume. There is an increased load on their heart. And when they become infected, they are more likely to get sick and have lung infections. We have had more women, pregnant women, in the ICU than ever before, than prior to COVID-19. And so pregnant women need to be aware that they can become sick and, unfortunately, die more likely. Maternal mortality during this pandemic has increased to crazy levels.
Is it known to what extent the immunologic changes that occur in pregnancy is playing into this?
There are different immunologic changes that affect a woman's status after she becomes infected. But she's more likely to have a different immune system, more likely to respond differently to COVID-19, more likely to have lung infections and other diseases. And more importantly also, is that because of her pregnancy, she is more likely to have a stillborn, a dead baby born, if she becomes infected.
I know both of you have been strong advocates for women of childbearing age and for pregnant women to get vaccinated against COVID-19. We should be explicit that the FDA has also recommended this, as has the CDC. But it seems like there's particular hesitancy among pregnant women or even women of childbearing age who may not be pregnant to get vaccinated. In your collective experience, what's motivating women to decline vaccination, given the fact that they are at higher risk, as you just explained?
Unfortunately, when you look at the numbers of women who have accepted vaccination, that number is terribly, terribly low. It's way too low. Probably less than 35% of pregnant women accept vaccination. It's really sad, really sad. And now a pregnant woman usually is concerned about her fetus, about herself. And the message that organizations and the CDC have sent out to pregnant women for a very long time is that they did not recommend vaccination until maybe about 4 or 5 months ago. So that is a carryover until today, when pregnant women said, well, you didn't recommend it then, why are you all of a sudden recommending it now? In addition to this, obstetricians, we feel, are not strong enough in recommending vaccinations. They may talk about it, they may offer it, but there's a big, big difference between recommending and offering. Obstetricians have been offering it. We have advocated for more than a year nearly that it should be strongly recommended. Pregnant women must get vaccinated to save their life and to save their baby's life. In addition to this, when a pregnant woman is vaccinated, she transfers the antibodies to her newborn, and the newborn is protected after delivery.
Frank, do you want to comment on that?
Absolutely. There's an important ethical point here. Respect for the woman's autonomy is paramount. But we know that the most important factor in the woman's decision-making process is what the obstetrician recommends. And hence, it's the obstetrician's duty to make a recommendation. When the evidence is clear, the obstetrician has a professional obligation to make a recommendation. Not just be wishy-washy and say, what would you like me to do? Give a clear recommendation. This is true throughout medicine. If I go into an emergency room with acute appendicitis, I hope the surgeon is going to say, we need to do a surgery. Not, let's have a discussion and what would you like me to do? That's exactly what Amos described. This is not a case for offering surgery or offering vaccination. You give a clear recommendation. There's been vacillation for too long, and I hate to say it, Ira, sometimes the obstetrician has medical legal concerns and is afraid that if he or she makes a clear recommendation, he get sued. This is a mistake. Sometimes you make a clear recommendation, and that's clearly the case with vaccination, and this has been the case for quite a while.
And unfortunately, there have been a lot of rumors about what vaccines can do in pregnancy. Most of these rumors are false, completely false. We now have more than enough data on hundreds of thousands of pregnant women who receive the vaccine, and it shows it's safe. It does. If a woman who is not pregnant receives it, does not affect her fertility. If a man receives the vaccine, does not affect his fertility. In fact, it does not even affect his sperm count. So that our patients need to be reassured that there's more than enough data that it's safe.
I mean, I've heard that are out in the media are impact on fertility. You're saying not true. Yes?
Let me explain just a little bit. This is all based on a letter written by 3 rogue, I call them rogue scientists in Europe. One of them written in German. I read it in German. And it's a false letter. It has a lot of false information. And even the scientists said the letter does not state that it affects fertility. It does not.
Okay.
In fact, one of the first women who died in Israel early last year, she and her brother were against vaccines because she wanted to be pregnant and have a baby, and she died. So she had neither.
Something needs to be said. We're Americans, we're proud of freedom of speech, but for professionals, physicians, and scientists, is a professional responsibility to be honest. And so much harm has gone on when misinformation is put out there. And I'm a strong believer that this is unprofessional and there should be professional sanctions, such as what's gone on in Great Britain. I've worked with my mentor, a pediatrician, when years ago there was a report put out in Lancet, a prestigious journal, that vaccine would cause autism in children. And in Great Britain, that doctor lost his license. I believe there should be professional penalties for doctors who spread false science.
So let me just drill down a little bit more on what you said a minute ago, Frank, about doctors being, I think you said, wishy-washy in their recommendations or making it available to women but not recommending it. And you cited the concern about legal action. Are there other things that's driving that physician hesitancy? We read a lot about patient hesitancy, but you're describing physician hesitancy. And I'm just wondering what else you think is responsible for that.
We have been criticized for publishing many papers where we support recommending certain things. Because we were said, if you recommend something, you affect a woman's autonomy, her ability to decide. And we feel that you must recommend something where the science is clear in order to strengthen her autonomy.
I just want to make one comment on that because I think Frank brought this up before, that I agree with what you said before about a professional obligation to make a recommendation is not the same as limiting somebody's choice.
We need to tell our patients, don't smoke,
right,
wear a seatbelt, put a car seat in your car. We must say that. If we don't do this, we don't fulfill our professional obligations.
And can I say this, Ira? This is in keeping with other professionals in society. If we go to a lawyer, he or she are not doing their job if they don't make recommendations to us. If we go to an accountant for advice at tax time, they're not doing their job if they don't give clear advice. And I emphasize this over and over. Shared decision-making is so important in obstetrics, specifically medicine in general. But when the medical evidence is clear, whether it's in obstetrics, medicine, surgery, any field of medicine, you give a clear recommendation and stand by it.
So let me move on a little bit from the conversation around vaccination to the conversation around birth and delivery. It's my understanding that more and more women are opting for home delivery, I guess based on fear of contagion in the hospital. So my first question to you is that perception accurate? Are more and more women opting for home birth in the age of COVID?
We just published a paper on this, and we showed that there has been a significant increase in home birth and in birth out of hospital birth center birth during the pandemic in 2021. There are many different reasons why more women opt to deliver out of a hospital. Now, the total numbers, I must say, is still low. It's still less than 2% of all deliveries, but the numbers have been going up. And before the pandemic, the reasons were that women felt not treated well enough. In the hospital, they felt constricted. They felt that there were too many interventions, too much internal monitoring, external monitoring, too much vaginal exams, too many IVs, this and this. And that's why some women chose more to deliver at home. With the pandemic, there are some women who believe that it's not safe to deliver in the hospital because of COVID-19, and nothing is further from the truth. We also have published on this and shown that babies who die at home are more likely to die of infections than those delivered in the hospital. And in the hospital, as you know, we do a lot of things to prevent infections.
Amos and I are very strong midwife advocates. In the middle of this COVID saga that we've lived through, the past 2.5 years, we've been very successful in instituting a midwife program at Lenox Hill Hospital. And this has been a challenge, and I'm very proud of this. We're midwife advocates. In our previous institutions, we've always been supporter of midwives. And I want to emphasize, most midwives in this country work in hospitals where delivery is the safest. So we support midwifery care, but not out of the hospital where there's a real risk to the soon-to-be-born child.
So let's talk about some of those risks. I can imagine some women saying, they're young, they're healthy, there's nothing gone wrong during the pregnancy. Why not deliver at home?
Here's the good news. Most deliveries, no matter what you do, will end up in the best possible way. However, when there are certain risks, and even when there are no risks, things can happen unexpectedly. And when they happen at home, you're far away from a hospital. It takes too long to bring the woman to the hospital. Frank and I have personally seen women who were transferred from the home and lost their baby, when in fact that baby could have been saved in the hospital. If a woman chooses to deliver at home, she needs to become aware of complications, potential complications, and importantly, she needs to also be aware that pain relief is not as well available at home as it is in a hospital. Epidurals cannot be done. Cesarean sections save babies' lives, and they're not available at home.
And Iris, something needs to be emphasized. When these disasters happen, the women are ashamed. They feel guilty. So these situations don't receive the attention that they deserve. They don't want to go public with this.
If we go back to what may be motivating women to deliver at home, especially now, what can you two say or do to reassure women that under the present circumstances, that it's still safer to deliver in a hospital setting? Maybe, Frank, you can take that first.
We have shown repeatedly in multiple publications, and Amos has been the lead author on these publications over and over and over, it is safer to deliver in a hospital than in a home birth or an alternate birth site. In fact, our latest publications, we use a controversial term. It's an immutable truth. It's an undeniable truth. This is the reality, and no finagling, no playing with statistics can deny this.
When a woman comes to me and asks me, I'm considering home birth, the first question I ask her is why? And that's probably the most important question to ask a woman. Why do you want to deliver at home? Some women had bad experiences in the hospital before. Some women see wonderful stories on YouTube and other social media of how beautiful. And I must tell you, if I watch some of those videos, they impress me too. They look wonderful. But you don't see the disasters. And that's something people need to become aware of.
And Ira, this is why I was determined to fight this uphill battle during this time of COVID, to establish a midwife service at Lenox Hill Hospital during this difficult time, to give women the option of midwifery care in the hospital where it's safe.
So to kind of answer both questions, right, to reduce the sort of medical intensity that some women object to and are trying to avoid by giving birth at home, but doing it in a way that still provides for a safe environment if something goes south.
Some hospitals need to change their approach to pregnant women. They need to bring a woman's home into the hospital and make sure that a woman feels comfortable and safe, that she feels like she can deliver in circumstances that she feels best with. Doing a medical intervention, doing a lot of medical intervention without the woman being aware of what's going on in her family is not the best way to approach.
Could you address specifically what you're doing about COVID to reassure people that it's still safe?
We make sure that all women get tested for COVID when they come to labor and delivery. And the shocking news is for you that across all Northwell hospitals, we have 11 labor and delivery units. 25 to 30% of all women test positive recently, last week, the week before, when they come to labor and delivery. That is a number that's unbelievable. And many of them test positive also because they didn't get vaccinated. Obviously, you can test positive even when you're vaccinated. But it's important to get vaccinated and to get boosted. We just had a woman who came just out, fortunately, out of the ICU, a pregnant woman, who developed severe lung disease and she was not vaccinated.
I want to emphasize that point that Amos just said. Of all the patients we've had at Lenox Hill recently who are COVID positive, many of them are asymptomatic, many have mild symptoms. Only one has been really sick. And as Amos said, has come out of the ICU and she'll recover, but she wasn't vaccinated. It's only the unvaccinated patients who get really, really sick.
And the boosted ones. As we know, the newest language is you're not fully vaccinated until you're boosted.
Right. So I want to go back to the connection between COVID and home birth. Are there other issues related to obstetrical care that you have seen disrupted by the pandemic?
Let me just say one thing, that doctors, very few, if any doctors, deliver at home. And that means that that pretty much gives a message to our patients. But in addition to this, those who do home deliveries, the majority are not full-fledged midwives. They are people who call themselves midwives who would not be considered to be midwives outside of the United States. They couldn't deliver babies in Canada, for example. And it's important for women considering home birth to realize who is the person, how qualified is the person who attends her at home, because that plays a major role in the adverse outcomes.
Ira, can I pick up on a question you just asked? I'm very proud of our service at Lenox Hill Hospital, that we have always demanded, even throughout the worst days of COVID and even today, that women in labor have their support person with them, whether it's their husband, significant other, even in the darkest days, even at the present time when there are no visitors in the hospital. So we have taken excellent care in conjunction with our excellent nurses. I'm very proud that that standard radiates at Lenox Hill Hospital.
And it's important for women to also know that they can bring their doula with them to the hospital. We will not prevent doulas from attending women, but doulas, like everybody else, need to get tested and have a negative COVID test before they attend a woman in labor, and they have to wear their masks. I think wearing masks and getting tested are important steps. Not always successful, but they're important.
Are there any places where you would recommend women go for more information about the subjects we've been talking about today?
PubMed. On PubMed, we have a lot of publications. If you enter Dr. Chervenak's and my last name and home birth, you get dozens of publications that will give you the straightforward information.
And vaccines as well.
The CDC website has a wonderful, and the American College of OBGYN, ACOG.org, has a wonderful information page for women who are pregnant and COVID-19.
So if I were to summarize our conversation, my takeaways are, number one, get vaccinated, maybe especially if you're a young woman who's pregnant or thinking about getting pregnant. Number two, it's safer, even in the age of COVID, or maybe especially in the age of COVID, to deliver in the hospital instead of at home. And number three, there are valid sources of information available out there, including from ACOG and other organizations that tell the story that we've just been talking about. Any last words either one of you wants to add to our conversation?
The most recent research has shown that a vaccination any time in pregnancy, first, second, or third trimester, provides adequate antibodies for the woman to be protected and for the baby to have these antibodies and get protected.
Frank, last word?
Ira, well said.
All right. Well, thanks very much to my guests, Dr. Amos Grünebaum and Dr. Frank Chervenak, for joining me today. For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.